So this is basically going to be a brief overview. It sounds like none of you want to do it, but you might change your mind and eventually want to do ophthalmology. It's a very good specialty in terms of the perfect combination of surgery and medical stuff, and it's a nice like lifestyle outside of work, and it's conducive to a lot of things outside of work rather than the stress that a medical or surgical job would give you. And it's very rewarding as well, and it's a quick reward because the stuff that we see, the outcome measure is only really vision or sort of pain, so it's easy to sort of benchmark how well you're doing. So can you see this first slide?
Yeah.
Yep. Okay. So any medical surgeon or GP or A&E doctor is going to need to know all of this. So I think in today's session and then in the session I think I got with you next week, we'll try and do all of this. You probably haven't seen many eye patients in the past apart from the rotations you've been on, but when you do particularly A&E and primary care and GP, you will definitely see eye patients. So it's useful to know because you'll get stuck if you don't know what to do. So we'll start from the beginning. So like anything in or everything in medicine and surgery, it starts with the history of why the patient's here. Now, most eye patients will come to you having been seen by their optician first. So I always start by asking the patient what made you see the optician in the first place, and then what has the optician said. And then you're going to want to know when did the problem start, because that will give you some details about what the diagnosis could be. Are you all in your final year or were you third years?
Final.
Final. So will you have an eye station in your OSCE?
Maybe. We don't know yet.
Have you've done the ophthalmoscopy has been assessed before, or it could be again?
No, it would be in finals. We haven't done it before now.
Fine. Okay. And are you ever in Bexhill or are you all at Conquest?
All at Conquest.
Fine. So we've, because of the pandemic, like bailed out of Conquest and all come to Bexhill. But what you could do is on a Monday, I know there's a clinic happening there. So if you want to use the ophthalmoscope, just to familiarise yourself with it, you could go down on a Monday and just ask them, could you have a play around with it? It's useful to know, because in the exam they might do what they did for me and have lots of different types of ophthalmoscope. And if you pick up the wrong one, you're a bit screwed. And then you look, the whole OSCE thing is about confidence. So if you look like you haven't seen this before, then the examiner will sort of potentially start to think to mark you down. Going back to the history, you're going to want to know if this problem is acute or chronic and how many episodes they've had, and then go into the associated features of that particular problem. Now, with ophthalmology, there's a whole host of medical systemic things that can be linked to the person. Often there's not, but if you don't ask these questions, then you'll miss that association. And like anything in medicine, you're going to be a bit of a detective. So you're going to, in your head, know who the suspects are or what the diagnosis is, but you're going to need evidence to get there. So all of your questions are going to hopefully pin you down to what this diagnosis is. The other usual things like family history and all the rest of it is still important with eyes. So you want to know about a family history of a squint. Do you all know what a squint is? Just say no if you don't know. So a squint, in the terms of what the layman might think a squint is when you're sort of narrowing your eyes to see properly, but what we mean by squint is essentially a lazy eye or an amblyopic eye, and it's when the eye is turned inwards or outwards, or upwards or downwards. So that's what a squint is. Someone who's had squint surgery would have surgery done to get that eye back into where it should be position-wise. Glaucoma is important because it's a strong family history with that. AMD, do you know what AMD stands for? Just shout out if you know the answer. No. So it's age-related macular degeneration. It's a very common condition we see in the elderly, and you will see patients definitely with it, probably on the wards, but they don't. But you haven't. No one's highlighted it, but the patients will know about it. And tumours obviously have some kind of genetic component to them as well. You're going to want to know about previous surgery, previous trauma, and amblyopia. Amblyopia just means the eye hasn't developed properly as a child. So after the age of about 7.
Excuse me, my slides aren't moving on. They're still stuck on the first slide. Like as though you have the, like before you press slideshow mode, you know.
Let me go. Is that better?
Yeah, that's better. Great, thank you.
I'll do it on this mode. So So previous, you're going to want to know about squint, glaucoma, AMD and tumours for family history. For past ocular history, you're going to want to know about any previous surgery, trauma, amblyopia. And amblyopia, like I said, is if a child hasn't had their vision corrected by about the age of 7, let's say because they needed glasses and didn't wear them, or they had a wonky eye, so an eye that turned inwards or outwards, then you kind of missed the boat in terms of recovering that eye in terms of vision. So that would be termed an amblyopic eye or a lazy eye. So if ever you see someone as a GP with an amblyopic eye, the vision will be bad, and there's nothing we can do to improve it. Past medical history, obviously things like diabetes and hypertension can cause massive eye problems, and things like asthma and COPD are more so because sometimes we use medications that might interfere with their breathing. Drug history, we're not so bothered about a drug history in ophthalmology, but things like the pill and HRT can cause optic nerve problems, so you might need to know about it if you thought there was an optic nerve problem. And social history, like smoking, is the big one because that has an impact on thyroid eye disease, AMD, and some optic nerve pathologies as well. But you'll find that whenever you do an eye clinic, there's not much talking because the organ you're wanting to examine is right in front of you, and you've got the kit to examine it right there. You don't need to wait for scans or anything else or blood tests. You're just going to go right in and have a look at what the problem is. It's a very visual specialty. So assessing the optic nerve, there's 5 ways to assess the optic nerve. So in your OSCE, you might have a station of assess the cranial nerve, the optic nerve. And as long as you know these 5 ways of doing it, you can't go wrong, really. So vision, pupil responses, color vision, fields, and fundoscopy. And you would be expected to know all of this as a final year. So the way we test acuity in the clinic is the same as how the optician does it, with a Snellen chart. So again, in your exam, they might have a Snellen chart there, and they might say, what do these numbers mean? Do you know what what the 60 means in 660? No? So it basically means that, well, these aren't sort of randomly sized letters. These letters are all being designed to create an angle within your eye. So they're all precisely done. So that 60 line, the top line, means that you should be able to see that from 60 meters away, but you have to be 6 meters away to see it. Likewise, if you're 36, then you should be 36 meters away, but your vision is so bad you have to be 6 meters to see it. In reality, our rooms aren't normally 6 meters long, so it's hard to put the patient at 6 meters and the chart 6 meters away. So we use a mirror 3 meters away, and then that mirror image is 6 meters. So you'd always put 6 at the top, and then the line at the bottom of the how you write it down, so 660 or 612. Normal vision is 6.6, and that's the same as 2020, how the Americans use feet and we use meters. If someone couldn't see the chart at 6 meters, you'd then move it to 3 meters and then 1 meter. So they still can't see that, you'd go to counting fingers, hand movements, and perception of light. People are very rarely sort of blind, pitch black darkness. That only really happens if you've had a massive artery occlusion or the eye's being removed. The legal limit of blindness is about 618. So actually, people who are certified blind still can see on that chart, but their visual fields are maybe very, very small. So they're walking around with a tiny, tiny central island of vision. You can also test near vision with standard reading plates. Do you know why we use the pinhole? Just say no if you don't know, just so I know you're still alive.
Nope.
No. So the pinhole, I'm assuming some of you wear glasses like I do. So if I took my glasses off and then tried to look at the chart, I'm probably about 660 with my glasses off. As soon as I put the pinhole up to my eyes, I'm 6.6. And that's because normally your cornea and your lens bends light. So if you're looking through a small pinhole, which is right in front of your eye, that light doesn't need to be bent. It can't be bent because it's going through this tiny hole right in the middle of your pupil. So it takes away the need for glasses. So that refractive error problem is usually diagnosed by the fact that pinhole vision suddenly improves massively. And if that's the case, then you'll find that prescribing someone glasses is the cure. Good pinhole vision also implies that your macula and retina should be working well because the eye is doing what it should be doing to that light. There are other types of Snellen charts. So if someone can't read, we ask people to tell us the direction of how the E is looking. And in the research world, we use other types of Snellen charts as well. Any questions so far? No. So going back to the people who wear glasses, so emmetropic means that you don't need any correction. The light that's coming in that distance is focused on your retina thanks to your cornea and your lens. Short-sighted, someone like me who's myopic, means we have short sight. So I can't see things far away, but I can see things close up without my glasses on. And because our eyeballs are longer than normal, the image is focused in front of the retina. So these glasses I'm wearing will be of a minus power to diffract the light back onto the retina. Likewise, long-sighted people have plus glasses to focus the light onto the retina because their eye is too short. So if you see someone with a minus prescription, it's short-sighted, plus prescription, it's long-sighted. Testing pupils is always a difficult one because it's difficult to do, and it's also difficult to in your head explain why someone has this sort of problem. But the easiest way, when I tell everyone this, the easiest way to think about it, the least complicated way, is just imagine what the eye should be doing. So if I shine a light in your eye, your pupil should constrict, and at the same time, the other pupil should constrict. So when you're swinging the light between the eyes, in your head, just think, right, this should be constricting. If it doesn't constrict, then you know there's a problem. I know only in an ophthalmology exam would someone ask you about this pathway, but when you're doing it on the wards and when you're neuro exams in A&E or on the wards, just remember the light pupil should constrict. But the reason it constricts in both eyes is because the pupil response, the parasympathetic system, is connected in both eyes around this area here in the midbrain. That's why you shine a light down here. The light. Can you see my mouse moving?
Yeah, we can see it.
Yeah. So the light shining in this eye, it's connected here in the midbrain. That's why the other eye will have a reaction. Likewise, when your eyes are dilating, it's a sympathetic system that takes over, which is a completely different pathway, starting from the hypothalamus, ending up in the iris, the dilated pupillary, where the pupil will can dilate. So at any given moment, this parasympathetic system and sympathetic system are working against each other all the time, depending on your levels of light. So in a light room, your pupils will be smaller. In a dark room, your pupils get bigger. These pathways, this sympathetic pathway is important to know about for all of you guys, because you might see someone with a Horner syndrome in A&E, and there's only a handful of eye things that can kill people, and Horner syndrome is one of them, because it means there's an interruption somewhere along the lines of this pathway. You'd obviously get an X-ray or a CT scan to work out what's going on, but whenever you see an abnormal pupil, try and sort of work out, okay, it's abnormal, it's more abnormal in the dark, therefore it could be this problem, or more abnormal in the light, therefore it could be that problem. And this is a small list of differentials of things it could be that you might not want to miss. And often we see people refer from the opticians who have asymmetrical pupils. Often it's nothing, but it could be something. And in particular, you'll definitely see some people with third nerve palsies. And if their pupil is large, that means they've probably got a posterior communicating artery aneurysm, and that's a neurosurgical emergency. If the pupil isn't involved, and it's normally just a vascular sort of problem, then the third nerve would be that classic down and out eyeball, and the pupil won't be affected at all. You would have heard of Horner syndrome because it's a medical thing. The other things you may not have heard of. Neurosyphilis you probably heard of, but you probably never see, and the others are quite rare. Any questions so far? No.
Sorry, can you just go back to the other slide? Sorry, your previous slide. What exactly is a Holmes-Ardell pupil? Is it just
a Holmes AD pupil? Is we don't really know why people get it, but it's a similar kind of pupil to how the Argyll-Robertson pupil is. So you get pupils that accommodate but don't react to light.
Okay.
There's no sort of it's more of a diagnosis of exclusion. So you would have gone through the other things and you're left with that, and there's no treatment for it. So you just say it's a Holmes AD pupil.
Oh, fine. Thank you.
The way we test colour vision is on the wards or in A&E, you probably wouldn't have these books, these plates, but that's how we do it in clinic. A good way of testing colour vision is to get something red and then ask them to cover one eye at a time. And then when they look at the red object, from one eye it will be red, and from the other eye it should be an equal level of redness. Someone, like a young lady with MS who's having an optic neuritis attack, will definitely notice that the eye, the optic nerve neuritis eye, there'll be some sort of washing out of the color. They often say it looks more washed out. So if ever you think there's an optic nerve problem or someone's got MS, hold something red up to each eye and ask them to comment on it, and it'll give you more of an indication of, okay, something is going on with their eye, because it should be the same. And the visual fields, you all know how to sort of test it. Ideally, this would be obviously face-to-face, and we'd go through this, but visual fields, you basically cover one eye, get them to cover the opposite eye, and you have to ask them to look with their open eye directly at your open eye, not your nose and not your forehead. So in the exam, just say, right, I'd ask you to cover your left eye, then you cover the left eye as well, of the opposite eye, sorry, and then you basically pupil to pupil, and then you create a X and Y axis around that pupil, and you present images in those 4 quadrants, usually a finger wiggling. So you start from the outside and bring it in, and it's a very gross way of assessing someone's visual field, because you're not going to pick up small glaucomatous defects. You're going to pick up people who've had a stroke, basically. That's the only reason you're really doing it in a non-eye scenario situation. Let me see if this plays. So if I said to you, one of you, to shout out the answer, if you had a lesion at 1, so I've cut your left optic nerve, what would the visual field look like in the right eye?
Normal.
Yeah, and the left eye?
You wouldn't have one, so it'd be completely gone.
Yeah, completely black, exactly. And in number 2? What if there was a lesion there? What visual field defect would you have? Let's say you're on the phone to your consultant and you're just on the visual fields, you picked up the problem, and on the phone you're going to describe to them what?
It's a homogeneous hemianopia, and that means that you're losing visual fields on the lateral aspects of both the left and the right eye.
Yep. It's not a homonymous it's a hemianopia, but it's the classic one you get with pituitary problems. So it's that bitemporal hemianopia.
Oh,
so the
sorry.
outside of your vision from each eye would be gone, and that you will definitely pick up with the finger testing, because it does cause that problem. And if someone's had a stroke in area number 3, that's when you would get the homonymous hemianopia thing. If I so there's some animations on here, but it's not, I can't play it. Can you see the revealed answer there or not?
No, we can just see black.
Let me, fine, under there was the answer, but basically always think of it opposite. So this is the left side of the brain, so you get a right-sided hemianopia. So on the right side of the right eye, that it'd be black, and on the right side of the left eye, it would be black. So once you go past the chiasm, everything is the opposite. But yeah, I went to King's, and my visual field station was exactly this. They had this picture, and they said, what's the field defect here, field defect here, field defect there, and they probably were wheeling a patient who has a bitemporal hemianopia. And it's easy to pick up because you will, that is a gross defect. So let's go into here. So have you all used an ophthalmoscope before?
Yeah, we've had teaching sessions on it in the past. But
and you've confidently looked at someone's nerve?
Kind of confidently. Yeah.
In the exam, like I said, at King's, we had a dummy head, and it probably will be a dummy head for you, given they want to avoid patient contact or whatever. I would probably advise everyone to keep your glasses on, keep that at 0, and then just slowly go in at an angle towards the nose. And as soon as you see something red or orange, then just gently flick one way or the other, and that image will come into focus. And once it's in focus, don't move forwards or backwards, because if you move forwards or backwards, you're going to go out of focus. So just stay in that focused position. And all you're going to really do, I don't remember the last time we used one because we never use it at all, but all you can really see is a 6-degree field. So it's a tiny visual field of the optic nerve. So it's basically to say, is the optic nerve swollen or normal? So in people with headaches and other neurological things, you will want to know if the nerve is normal. But again, like I said, you can go to Conquest, or even if you can come to Bexhill, we have 24 hours. We have 5 days a week. We have clinics going on here. So by all means, come to Bexhill and we can show you how to do it. So this is a picture of the whole eye, the back of the retina, and all you will see with the ophthalmoscope, like I said, is the small patch of the optic nerve. We use the slit lamp and another lens, so we just see a section of this, but we move left and right. So then we actually cover the whole retina. So that in reality, this is what I see, this kind of picture, without using the ophthalmoscope. This is the optic nerve. This area here is the macula. The middle bit is the fovea, where all of your cone photoreceptors are. So your color vision, all your good vision comes from here. Good vision doesn't come from over here. It's all from here. So any small problem here will give you a central visual field defect. The nerve has all these blood vessels coming out of it, which supply the retina. And the thicker ones are the veins, the smaller ones are the arteries. So the arteries come out of here, go to different parts of the retina. There's a huge capillary network, and blood goes back to the veins, back through the cavernous sinus, back to the heart, basically. But from your point of view, from the exam and the optic nerve assessment, you're going to want to know about the color of it, the contour of it, and the cup disc ratio. You can look at the vessels coming out of it, but it involves you sort of tilting your head and then following them, but you're not going to see much at all. Do you know how to assess the macula with an ophthalmoscope? What would you ask the patient to do? Anyone?
Yeah, no idea, sorry.
So you ask them to look at the light. So when they're looking straight at the light, because all of your central vision comes from the macula, then you'll be looking at their macula. So you'll be able to see very quickly if there's anything abnormal there. But it's difficult because they're looking at bright light, so they're not going to want to do it for long. So like I said, well, I don't remember the last time I used an ophthalmoscope, but you would use it in people who are wheelchair bound, or children, or someone who you can't examine on a slit lamp. This cup disc ratio business, do you that can be difficult to understand because it's easier here. So up here, you can see that the whole optic disc has this small cup in it. And then you can appreciate in this picture here, this cup occupies more of a distance. So this, you would say the cup disc ratio is about 0.3 or 0.4. This you'd say is about 0.7 or 0.8. So the bigger the cup, and it shouldn't be that big, it might be big in people who are myopic, but if there's a high cup disc ratio, it's a sign of glaucoma. So that might be an exam question they ask you, because when you look at everything that you do has got to be for a reason. So when the examiner might say, okay, you've looked at the optic nerve, and you've commented on the cup disc ratio, it being normal, which is about 0.5, 0.4, they might say, what's it indicative of? And you can say, well, it's chronic glaucoma can cause an increase in the cup disc ratio. There's not much else. There's nothing else actually that causes that. So normally this would have an animation and answer your questions, but it's all come out anyway. So the easiest, this is a very simplified way of looking at things in the back of the eye. So anything yellow and shiny is probably an exudate. And that represents a leakage of blood vessels. And when the blood vessel leaks, the protein leaks with it. But the fluid gets resorbed, but the protein, because it's too big, stays behind. And that's what you're seeing is these yellow blobs in the retina. So someone who's hypertensive or diabetic or lots of other things, you can get little exudates there. In the exam, no one's probably going to want the diagnosis in the ophthalmology station, but they're going to want to know that you can see with the ophthalmoscope. So anything bright and yellow is probably an exudate. Or they might show you a picture, in which case you just say the word exudate. If it's white and fluffy, it's probably a cotton wool spot, like here. Do you know what a cotton wool spot is? Anyone?
Nope, sorry.
No. So it's a little focal area of ischemia. So again, someone who's hypertensive or anemic or any kind of vascular problem, when the retina is ischemic, it turns white, and that's why you get these little white fluffy bits. These pale circles, black bits in the middle they look like little bullet holes, but they're man-made, they're laser scars. So the whole, the way we used to treat diabetic retinopathy, and to some extent still do, is by doing laser, because the retina can only do certain things, and the one thing it can do is its blood supply can shut down from these other diseases. So once it's shut down, the eye will want to make new blood vessels, what we call proliferative blood vessels, neovascularization. So the way we tell the eye to stop doing that is to laser the ischemic areas, so really destroy them, so there's no more of a drive for the eye to make these new vessels. So by doing the laser, we're saving the eye from getting recurrent bleeds, because new vessels will bleed, but you're constricting their visual field. So all these young diabetics, I had a few today, who drive, you're essentially making their driving license void, because with a constricted visual field, you can't drive a car. So as soon as you tell people that, then they realize actually they've got to take their diabetes seriously, because they're going to stop driving. So often we see people in their 20s and 30s who have stopped driving, they've got families, because they haven't looked after their sugar level and they've needed a laser. So anything red in the eye is obviously blood. These are what those new vessels look like. So they're just very fine and abnormal. So if you looked at someone's disc, you should really just see chunky vessels coming out of it. But if you see very fine vessels, that could be a sign of optic disc neovascularization. So that could be in your exam as well. So geographic atrophy. Atrophy means just dying or thinning or wearing down of the retina, and that's common in macular degeneration. So this person's macula has this massive atrophic spot. So their vision centrally is probably 660, but if they turn their, or worse than that, if they turned their head and fixated slightly off that patch, their vision might be 6.6. So that's why it's important to test vision straight on without them turning their head, to know exactly what a good reliable way of testing the vision. Eye movements will probably be in your neurostation, or in general life you will probably do these this aspect of the neuro exam. You just need to know that that's the H that you normally do, and you have to always look at the patient's eyes when you're doing it. Don't just do the H and follow and look at your finger, because you'll miss what their eye is doing. So I've been in exams where people have got an obvious, say, 6th nerve palsy, so the eye can't go outwards, and they've missed it because they've just been, probably because they're nervous, but they've just followed their own finger and not concentrated on what the patient's doing. In the exam, the patient will always have a problem. They're unlikely to rule a normal person out. So just always look at their eye and ask them about their double vision, and know which optic nerve, which cranial nerve supplies which muscle. But basically, it's either 3, 4, or 6. So going on to things that you might see on the ward without a ophthalmoscope or slit lamp. So you probably have seen people with weird lid lumps before, and you will see again, particularly in GP land. So if this came to you, you would be worried about a basal cell carcinoma or squamous cell carcinoma, and it's usually from sun damage. But the telltale sign here is that the lashes have gone. So if ever you see a lid lump and the lashes have disappeared, it's a bad sign. So they need an urgent sort of biopsy to work out what's going on. And that's more typical of how BCC and SCC look like. They get that raised, pearly appearance with blood vessels supplying it. They can be away from the lash line as well. So you've probably seen lots of people with warts. These are called squamous papillomas. They're completely benign, do nothing about them. Before, when I first started ophthalmology, we would be allowed to remove these, but now, because of all the rationing on the NHS, you can't have these taken out. But we still do sometimes, and just don't tell anyone. Other things like sweat glands can pop up, and then you can get little fluid-filled cysts like this, and like this, which is a sebaceous gland. This is a more common thing you will definitely see. So in A&E, almost every day we'll get a child with a lid lump like this. And the worrying thing about these lid lumps, which are called chalazions, what is the worrying thing about them? When you're in A&E and you see this, how do you treat this? Someone just describe that top eyelid. Shall I pick a name? Elliot? Yes. How? Okay. How did that? Just describe that to me, to all of us.
It's so on the upper eyelid of this person's left eye, you've got a red area spanning approximately the whole width of the upper eyelid. It appears to have like altered contour because you can see from the reflection it's like bulging out. It doesn't appear scaly or like there isn't any surface change other than the color. Hang on. Sorry, something just appeared in front of my screen. Okay, there you go. So we've done the size is, the width of the eye, shape seems quite smooth. Color, as we've been through, is red. Surface, I said as well, smooth.
Is it more lumpy in one area than the other?
I think it appears slightly more lumpy. Yeah, where your cursor is.
Would you say there or there?
Well, it appears to be more bulging laterally, but where your cursor
exactly.
is, the texture appears slightly different. Yes.
Yeah, so this is all swollen, but this looks more swollen, doesn't it?
Yeah.
Over here.
And the sclera itself is, white, which is.
Yep. Good.
And the eyelid doesn't appear flaky. It doesn't look like blepharitis.
Yep.
So, in terms of what this could be, I can never pronounce it, chalazion, or it could be periorbital cellulitis. Or
so what would be if we left this on? Can you see the title at the top there?
Yeah.
So this is a chalazion, like you say, with preseptal cellulitis. Do you know what the word preseptal means?
Does it mean like before it's? I'm not sure where the septal is in this instance, but does it mean before it's like crossed some sort of barrier?
Yeah,
like
exactly. So we split the eyelid structurally into sort of a front and the back. So this is in front of that almost imaginary plane. But it means you can get away with treating this just with tablet antibiotics. So you can see the skin is infected because it's red and inflamed and probably quite hot to touch. And then it's very common in children. And they're often in pain. Vision's normally fine if you can lift the lid out, but they would need tablet antibiotics. When would they need IV antibiotics?
If it goes
yeah, so if this infection went further back and it becomes orbital cellulitis, then that's much more of an emergency, and that's a sight-threatening and sometimes life-threatening emergency. So they need IV antibiotics in admission. They also need probably ENT to have a look at them because you can get sinus problems that have caused this cellulitis. Often though, and that would normally number one thing is a subperiosteal abscess, which would need draining by the ENT team. But often when you see cases like this, some of you may have had this, it's just in the anterior part of the eye where your eyelashes are. There's a small gland that secretes oil, and if that becomes blocked, you get this. Can you see that sort of pouting out there? That yellow block there, that is where the oil gland has become trapped. So because the oil which we normally need for your tear film to work properly has become blocked, it can't go anywhere, so it builds up like a spot. So the way you would treat that is to get a hot towel meaning you get a little face towel, run it on the hot water tap and just put it on here and push. And that over time, we're talking weeks, would slowly get this to be smaller. And also you'd give them tablet antibiotics. If it wasn't red, they don't need antibiotics. You just need the hot towel on it. But if you got go on.
Incisions and stuff to drain it like INC, or was that just more textbook stuff?
No, so definitely, yeah. So if this was rock hard, then and it'd been there for a month, let's say, then it's probably not going to go away with hot compressing. So then you would do something like this. So it's a minor procedure. So you'd obviously local anesthetic, flip the eye inside out, and then make a tiny cut in the conjunctiva. Conjunctiva, you guys probably think the conjunctiva just ends in the white part of the eye, but it actually reflects back on itself to the lids as well, which is why you can never lose a contact lens. People often think when your eye rolls back when you sleep, a contact lens will disappear, but it can't because it just gets folded up in the conjunctiva. But you'd make a small little cut there, and then all the yellow crap basically just comes out, the oil, and then it's gone, but it can come back. So the definitive way of treating it is INC, but you don't really want to get there. You want to just treat them at this stage with antibiotics and hot compressing. but they can be huge. And again, with the NHS, unfortunately, before you could do this on anyone, do the INC on anyone, but now you have to wait. I think they have to have 6 months of symptoms before the CCG will pay the hospital to do the operation. Again, there are ways around it. You just lie and say they've had it for 6 months, but there you go. Some things can be, obviously some cancers can be very dangerous. The sebaceous gland carcinoma can look a lot like a chalazion. So if someone's got recurrent chalazions, but again, you can see the lashes look a little bit different here, then you should always do a biopsy. And because it could be a sebaceous gland carcinoma, which can kill people. And sometimes when you need to do the biopsy, after it's told you that it's a sebaceous gland carcinoma, you have to take out the whole eye and the whole orbit. So it's called exenteration. So it can be massive. More common things you will see in A&E. So a foreign body on the cornea, you'll definitely see in A&E, and I guess it's up to you whether you want to poke around and try and get rid of it. A cotton bud won't do anything. So if ever you see your registrar or consultant with a cotton bud trying to do something, it's not going to do anything. In fact, it's probably going to push it further into the cornea. You need a needle to get under that. So have you all used a slit lamp before? Probably not. So in all A&Es will have a slit lamp. So just familiarize yourself now with a slit lamp, because at some stage you probably will use it. But nobody would ever sort of have a go at you for not taking it out, because it's just a confidence thing. You don't see enough of these to be good at them. So you just send it to us within a day or two. Any contact lens wearer with a red eye, you should think of this problem as number 1 on the list. And this is a blinding condition. So bugs in your contact lenses can erode through your cornea and then your eye, and then you've lost your eyesight and your eyeball sometimes. So at this stage, you want to treat it. Do you know why it's green? Anyone?
Is that after you've used some dye and the dye focuses on where the cornea is eroded?
Yeah, exactly. So the fluorescein, sodium fluorescein is what we put in, which is a orange dye, and then we flick our light to a blue light, and the corneal pathology will highlight as green back to us. But red eye contact lens wearer, think of a keratitis. You can see these weird just cysts in the eye. Sometimes it can be orbital fat protruding, or others just a fluid-filled idiopathic cyst. Often we will lance this with a needle, but often people just say just leave it and it sort of stays there or goes away by itself. One of you mentioned scaly skin, so blepharitis is very common. So if you, which is basically like having dandruff on your eyelashes. So if you get recurrent episodes of dry eye, it can be because of blepharitis. So anyone who's got an gritty eye in A&E or GP, always start them on dry eye drops. There's no side effects to them. So dry eye drops, and to clean their lashes with a cotton bud and warm water to get rid of all this gunk, and that will open up their pores to make their dry eye better. You will definitely in GP land see people with blepharitis and dry eye. Episcleritis is a focal area of redness on the sclera, the conjunctiva, and that would be treated with usually topical steroids or maybe just lubricants or oral NSAIDs. And there can be some systemic associations with it, like rheumatoid arthritis or SLE or GPA, Wegener's granulomatosis. So lots of inflammatory systemic conditions can cause inflammatory eye conditions. That's why it's always important to think of that differential of what could be going on. Pterygiums are very common. So whereas episcleritis was just here, this has actually extended onto the cornea. So in people who are born in or have lots of sun exposure, you'll see this really, really commonly. Often it doesn't cause a problem, but you can imagine if this goes onto your pupil margin or covers your pupil, then you'll be blind. So at this stage, we'd probably shave this back and put a graft on top of here from the conjunctiva to fix it.
Is it like a sun-damaged sclera then? What is it?
So the UV light in the sun has altered the cells in the sclera, and it's caused it to proliferate. So the proliferation will, some people, it goes onto the cornea and it just causes all kinds of problems there. Your cornea has to be completely flat and regular for you to see properly. So as soon as you get any alteration to that, you're going to have vision problems. But yeah, we would only operate if the vision was affected. Do you all know what, I put the diagnosis there, but what exactly is going on here?
You get like the dendritic spines of herpes simplex.
Yeah, exactly. And how do you treat it?
Sorry, what did you say?
How do you treat this?
Acyclovir and other antivirals.
Yeah, so acyclovir tablets or cream?
Cream.
Yeah, exactly. So when you see people with shingles, so herpes zoster ophthalmicus, where half their or a patch of their face has got it, you would give them tablets because the cream's not going to do anything. Often, if the tip of the nose is affected from this HZO, then you're pretty sure that the eye is probably going to be affected as well. In which case, you would then give them tablets as well as acyclovir ointment for the eye. But commonly, you can just see herpes simplex affecting the eyeball with no skin problem at all. And often it's just the front of the cornea that's affected. But this herpes virus can go deeper into the cornea and into the eye, then they would need IV or tablets. But yeah, topical acyclovir 5 times a day for a couple of weeks, and that will heal up nicely. Do you know why the corneal sensation would be reduced? Yeah. So it's to do with the trigeminal nerve. So all this herpes has traveled down a nerve to get here. So because the trigeminal nerve has been affected and your corneal sensation comes from that, you get this lack of corneal sensation. So we often get a little piece of tissue and touch their cornea and they won't feel it at all. And then you know before you even examine them that they've probably got some hepatic lesion on their eye. How would people get this corneal abrasion? Anyone?
Through trauma or through maybe contact lens use or touching their eye or something like that?
Yeah, there's loads of reasons. And again, you will in A&E see this. Often it's builders who've got stuff in their eye that have caused this, but you'll see off a sports field, you'll see lots of this, like rugby players, and they're mostly treated all the same way. So you would put fluorescein in. How could you tell if this was a full thickness, other than obviously the contents of the eye hanging out of that hole? But how could you tell if it's full thickness or not? Any ideas?
Does it not go green because like the green is just on some of the cells slightly superficial to like slightly deep to the outer layer?
So it would still be green, but what's inside the front of the eye? So you've got the cornea, the dome, and then you've got the iris.
Anterior capsule of the eye with the fluid. I remember the name of it.
So you've got the aqueous fluid.
Yeah.
In the front. So you can think of, if I was to get a needle and put it through the cornea, aqueous fluid would start gushing out of there. So when you put the dye in, often if there's a hole in the eye, this dye will start to run, and you see a waterfall of basically green fluid coming down. And that's called the Siedel's test. So if the Siedel's positive, you know the cornea integrity has been breached, and then you know you have to take them to theatre and stitch it. Whereas if it's just an abrasion, the dye doesn't move, you can be pretty sure that it's not been breached and it's just the top layer of the cornea that's been eroded away or abraded away. Another thing to say is the pupil should be round. So if the pupil is not round, and you will see trauma cases, you've got to ask yourself, why is the pupil not round? So it might be because there's a hole somewhere and the pressure in the eyes change and it's dragged the pupil in a certain direction. You'll definitely see trauma when you do A&E, and you will see eye trauma. So just always be careful about how you touch the eye, because if someone's got an open wound and you're sort of bashing around with the eye and lifting it and asking them to open their eyes and all this kind of stuff, it can make it worse. So I would have a low threshold in those cases just to call the on-call ophthalmologist to come and have a look. And then we would do like an ultrasound or other things to just be more gentle and probably take them to theatre to fix it. I think that's it for this. Does anyone have any questions? There's probably a lot to go through.
I just have a question about the fundoscopy, if that's okay, about because I don't think I've never actually seen optic nerve swelling in real life, so I'm not sure I'd be necessarily be able to recognise it on a picture. So is it essentially that I suppose one of the features of it is it literally that it is just bigger, that you can sort of is it about knowing what its normal size is and having that in knowledge, or is it quite obvious that there's something is swollen?
It's not really about the I'm teaching you next week as well, aren't I?
I think so, yeah.
Yeah, so I've got pictures of swollen disc then, but it's more to do with the border. So
Okay.
if the border of this disc isn't a crisp line, and it's irregular or jagged or just not a crisp line, there's something going on. It's
Okay.
less to do with the size of it. So if you see a sort of fluffy contour, then it's probably a swollen disc rather than the size of it. But it is obvious. It's not going to be, and from an exam point of view, in OSCE, it's definitely going to be obvious. They will show you a picture, most likely.
Sure. Okay, cool. Thank you.
Any other questions?
Yeah, I have another one. When you mentioned geographic atrophy, could you just talk about the test you mentioned? So I missed it.
Yeah. So if someone's geographic atrophy is a form of macular degeneration. So there's no cause for it. It's just age has just made the cells in the eye die off, and it would look flat on other kinds of scans that we do. So whereas the retina has a certain thickness to it, in this area here it would be completely flat and their vision would be poor. The way you assess that is with an ophthalmoscope, is getting the patient to look at the light, and then you would then automatically be focused on their macula, and it would look different. It wouldn't look like the nice orange normal color that you see like this over here. It would look white probably, or yellow like that. But it's hard with an ophthalmoscope to do that because the field of view you get is tiny. But anything atrophy is basically thinning, so the vision's not going to be good, and it's normally a sign of a chronic disease rather than an acute pathology going on.
Okay, thank you.
I've not convinced anyone to do ophthalmology now in 49 minutes. No. Fine. If you have any questions, just email me, or if you want to arrange, I can find out. I don't work in Conquest normally, but I can find out who is there. So just email me if you want to go and use an ophthalmoscope, because we do have some clinics running there, like I said, on a Monday, I think it is. So just let me know.
Thank you very much.
No problem.
Thank you.
Thanks.
Thank you. Bye.
Thank you.
Bye-bye.
Thanks. Bye bye.